So someone to understand how I manage second and third line metastatic colorectal cancer is what I do for first line therapy. And initially when people are diagnosed, I do, as soon as possible, try to get next generation sequencing as well as microsatellite instability status, either by IHC, doing a mismatch repair, or by PCR, MSI, or now with next generation sequencing, looking at mutational burden. Most of those don't come back by the time you initially start someone on first line therapy. And so my initial discussions with patients are using either FOLFOX or FOLFIRI, and typically I give most patients bevacizumab. I don't personally use the right and left to decide regarding cetuximab versus bevacizumab. I think that bevacizumab is appropriate for either. That's how I interpret and use the data. And so then that influences what you do in second line, is what they've received in first line, as well as what their mutational statuses are, right? So if it's a patient who's KRAS mutated and they start with FOLFIRI bevacizumab, they'll get FOLFOX bevacizumab, so I continue bev in second line. If it's someone who's BRAF mutated, I'll typically turn to using some type of BRAF mutation, BRAF inhibitor with combination therapy, either on trial, of which we've fortunately had some trial opportunities for these patients, or been pretty successful at getting off-label use of some of the inhibitors that have been tested already. If it's someone who's wild type in both and not microsatellite unstable, then consider either irinotecan cetuximab or FOLFOX. And the real one question is when to fit in. If you have someone who's microsatellite unstable, when do you fit in immunotherapy? The current indication is for patients who have progressed on all their standard treatments. But I think a lot of us will use it a little earlier. I don't typically use it in first line, but I'll certainly consider it in second line for these patients after initial progression.